So my talk today, my duty today is to share with you about my concept that I use for evaluation and the CT scan and the surgical indication. When we are the orbital surgeon, we know that this is the clinical that we have found every day. The patient with the trauma is going to be the acute one or the chronic one. And most of the problem that make we have headache is a restrictive strabismus and growth displacement. But our goal as an orbital surgeon or oculoplastic surgeon to bring everything back to normal as in the right lower video. The eye movement, the goal position is so important. The fracture is not the diagnosis, but the size does not determine the surgery. The function is the most important that we need to bring it back. For the timeline that we deal with the CT scan or imaging, it started in 1980. But after that, they developed the DICOM system. And after that, the PAC system, the multi-planar reconstruction. And if you are the Mac, I'm the Mac user. They have the application named Osiris. And then develop to be Horos. You can get this one download and free. And if you are the Windows, they have another one also. Nowadays, we can use the application to our own and create the 3D imaging, and be more understanding. And in the future, I think the AI and can be developed many insulating issue in the future. This is a software in the Mac. On the left-hand side, I would recommend the Horos and the Osiris. And if you are the Windows user, you download about 3D slicer. This is one of the best. For the indication, for the conventional indication, we all know that this is an indication. Diplopia, orbital tissue entrapment, is no improvement in 2 weeks. Enophthalmos more than 2 or 3 millimeter, proptosis, large defect more than 50%, or any rim fracture. But the concept nowadays, in my own concept, it makes everything is so easy and practical. If the patient come and they have the fracture of the rim and zygomatic complex fracture, we need to fix that one first, and then we fix from the outside to inside. If we need to deal only the floor fracture, that's more complicated. If the surgeon is not the oculoplastic, sometimes they just deal with only the front part of the orbit. They cannot, and that's not there enough to go deeply to the optic canal or the optic nerve. This is the classification that I use in my practice. 1, 2, 3, 4, 5. We can fit with the simple orbital implant. It's going to be commercial one. But if you have found with the grade 6, they're going to be the very bad fracture, no support at all. So we're going to see the two issues that I want you to bring it back today when you see the scan. The first one is the orbital stud, and second is posterior ledge. As we know that we need to have 4 points at least for the support in the concept. Medial orbital rim, lateral orbital rim, and inferior-medial orbital stud, and posterior ledge. This one. Let's start with the orbital stud. The orbital stud we divide to be 3 parts, anterior part, mid part, and posterior part. And for the posterior ledge, it's so important that when we do let me start with this one, sorry. This is the orbit. When we create the user application to create the fracture, we're going to see the orbital plate of the palatine bone and the body. This one going to be the big important part. If you cut with the application and you can learn about the cross section number 1, learn about the axial view and see the area of the intact of the palatine bone. This will be the very important support part in the back. If the palatine bone or the posterior leg have been fractured, we have the difficult time. Sometimes we put the implant in the back part gonna drop inferiorly. So at least we need the 3 point for the support. When you put the commercial implant, maybe titanium or the PMMA, we need the 3 support. This is the 3 support, 1, 2, 3 in the back. So it's stable enough to make the implant stabilize for the rest of the life. And if you have 3, another 3, one is one in the front, medial lateral, and the orbital stud, at least 3 need to be important to support, and then fix with the screw. So let's start with the simple to the difficult. The first one, isolated orbital implant. This is 51 gentleman have the motorcycle accident, and even though he put the helmet, he got the big fracture on the orbital floor. And they have the marked double vision, restrictive strabismus in the vertical dimension. You see deep superior sulcus on the right side. And he have double vision all the time, even though he make the primary gaze or reading or up gaze. So he cannot live with this. So we start to do the CT scan and evaluate. This is the axial view. We see the orbital plate of the palatine bone. In this case, you see it's positive for the orbital plate of the palatine bone. So this is going to be the easy case. So the next one, you see with the coronal view, you see the strong intact of the orbital strut. This is going to be the good clue that we're going to be happy when we do the surgery. Last one, the sagittal one, we see the normal slope of the orbital floor first. It come up about 20-30 degrees. In this gentleman, he got the 50-60% of the floor fracture. But the good point, the good news is the upper orbital stud is good enough, and the posterior leg is good enough. So it's going to be easy and stable when we perform the surgery. Next one, if the large orbital floor and medial wall fracture without the support, how can we see with the scan? And this lady, she is a drum major. When her colleague throw the drum major and hit to her orbit, they have a really big fracture for the whole thing. And her globe got posterior globe displacement significantly. He has no double vision, but the position of the globe turned about 1.5 centimeter. That's going to be a tough one, and she have the minimal vertical restrictive strabismus also. Let's start with the CT scan. For the axial view, we can see the very large fracture on the medial wall and all the floor, and you can see the orbital stud have been gone. In this one, you can use the mode in the CT scan by the application. You use the ruler for measurement. And you can see on the sagittal view that how bad, how big for the floor. The previous surgeon did wrong for the correction. He just go in and put the implant, but no volume augmentation. So that's the bad part. So the next mode that is really helpful is called 3D dimension surface rendering mode. When you play with this one, you can be very fun. You load the application, put the CD-ROM in your file, and put at the 3D rendering, and go to the high quality. You're gonna have these images at home. You can learn at the night before the surgery, remember the normal side, and remember the abnormal side. Remember every angle, every dimension of the orbit, and then you remember it in your brain. And when you go to the surgery, it's going to be very practical and easy. So this is the example that 3D dimension about the CT scan show lots of the all support. We can go super deep, zoom in, zoom out. And if we put the regular commercial implant, what's going to happen? The posterior part, no support. So you can see the implant drop down posteriorly and inferiorly. So this is going to be like under correction. So when we put the scan to the lab, to the 3D printer, we got the rapid skull model prototype. So it's going to be very easy for us for doing the surgery more than conventional day or the previous day. The next mode, 2-dimension orthogonal MPR. This is a cool one. When you use the app, you go to mode and click at the 2D orthogonal MPR. It means viewing a CT scan simultaneously in 3 planes and are mostly perpendicular to each other. So I do encourage you to see at the same time on 3 views. So you can remember every angle, every contour, every shape of the fracture, and remember again in your brain. So when you go into surgery, it will be, you remember everything, so you're gonna dissect the soft tissue easily and confidentially. So in addition, this lady, she got the motorcycle accident and have the very bad fracture. So it's gonna be the tough one. So the lastly, nowadays, I do encourage you guys to use the CD-ROM, learn by yourself at home, by the software, and get the rapid prototype every time as much as possible. So you can put that one, just shorten the surgical time and more precise. When 20 years ago, when I graduated the fellowship, I just used the 3 axial chronosectional and remember and go in and go out with the implant. Nowadays, we got the rapid prototype and sterile in the operation room. And we use that one in the operation, and we put the implant on the skull model, cut it, shape it, bend it, and then put it in one time. No need to bring in and bring out. So that's gonna be stable and precisely. So the last one that's so cool is about the orbital volume calculation. You can use this one for fun. In the application, you go to the mode ROI. ROI is mean region of interest. You just put that one to the close polygonal, and you go start from the deep orbit to the front part of the orbit, and you label about the contour and the shape of the bad orbit and the good orbit. And then you rename the region of interest. And the application software gonna be calculated and from the back to the front. And after you rename it, you just compute it. And ROI go to the ROI and computer volume. So the software will calculate the whole volume for us. In this case, in the fracture side, we saw that 31 cc, and on the left one, 28. So you see the difference. You can use this one for education, your research, and show your patient. So thank you very much.